Okay. Uh, Dear doctors, dear colleagues, so I would like to say good morning for my European colleagues and good evening to my Chinese colleagues. So today we will have a session about the innovation and the novel strategies in CHIP PCI hosted by ProsMed industry. And as we know, recently there are many complex PCI, and especially in no matter European countries and both in China, we have more and more very cheap patients. So how to prepare the lesion very well, I think that's very important. So today, we will have several speakers tell us the experience and the innovations. So firstly, I would like to invite Dr. Carlier. Please 把他那个简历 OK. Dr. Stephane Carlier is a professor of cardiology in University of Mons, Belgium. So he is a consultant interventional cardiologist at Ambroise Père Hospital in France. So firstly, welcome Dr. Carlier give us the first talk.
Thank you so much for the kind introductions. I was trying to find a more peaceful place to present because I'm in the middle of a cath lab, just busy in some session where we are demonstrating imaging for CT opening. But as you know, I'm a strong believer in imaging, and I would like to be sure that you see correctly my image now of the presentations, and you hear me loud and clear.
Yeah, please go ahead.
So then I would like to take one step back to all the problems that we assess once we are dealing with calcium. And you are well aware of the issues of not advancing our material in the lesions, not opening correctly the stent, or having even the rupture of some material. And you know that we have many tools to assess the calcium, from coronary angiography, that is a poor tool, to CT, to intravascular imaging with IVUS or OCT, and the details on the calcium and the amount of plaque burden will be better defined with intravascular tools. But I would like to bring one step further, and in the future, I strongly believe that all the developments that we are seeing in CT imaging will offer us a way to better assess the calcium and the difficulties of some PCI well in advance. We are now with tools allowing us to even estimate the thickness of the calcium or the ounce fill unit in order to see if this is going to be a lesion very difficult to open. And this is also possible now with some AI behind to assess the plaque burden in advance, and we can define where, for example, we will have to cover a lesion to go from a healthy segment to another healthy segment. And next to this, we also have the possibility to do some physiological assessment, so that I think that combining all these tools and going back to better understand what we see inside with a much better resolution. Of course, it will always be necessary to have the detailed information from an OCT of an IVUS in order to understand subtle change like what we are describing now on the nodular calcium, that can be sometime active and more promoting ACS versus a more stable nodular calcium. This is important when we are doing the procedure, but it is also important to know in advance if we will have to use additional tools. And you know, this classification based on OCT that depends on the length of calcium, the arc of calcium, the thickness of this calcium, so that there will be predictable stent under expansion. There are similar work that has been done from the IVUS analysis from the group of CRF, and you see that you will have other parameters because on an intravascular ultrasound, you cannot measure the thickness of the calcium. Well, you can try to derive it indirectly by the presence of reverberations. You see that in these studies, clearly there is an underestimation of the calcium burden just with your angiogram. And I will take back to what I was showing on the first slides. You see better the calcium from a CT assessment than from your angiogram. Sometimes we hear that it's not possible to use IVUS if we are looking at calcium. It's better to use OCT. I think both imaging have advantage and drawbacks, like using a lot of contrast with the OCT. What is true is that sometimes you underestimate the presence of calcium if it is deeply seated in the vessel wall, so that basically, in that study, you were seeing more often calcium on IVUS than on OCT. We have now some charts in order to decide when and which specialty balloons, scoring balloons we can use in order to have the better preparation of the plaque based on this imaging that we are doing that will be non-invasive or invasive. And I would like to take you to one example, a classical lady with risk factors. And we have been doing the CT in advance. And this is how she is finally arriving in the cath lab. And you can appreciate here the CT and the assessment of her lesion in the mid-LED. I will play this movie in order to be then following the full handling of her coronary artery disease. I was wondering, do you have the sound of the video going through?
No, no.
Because that was the problem. So I wanted to be sure, because the video is playing with some comments. So I was for once not saying anything. But if you don't have the sound of the video, then you cannot follow exactly. So it's now important to know that you are not hearing anything. Sorry that it took 1 minute to realize, but so this is the time where we are dealing with this bifurcated LED lesions, and we are going to predilate in the diagonal branch, and then in the LED, we saw the calcium. We are then using the predilatation that we will see coming. You see all the calcium that we were seeing with the CT, and at that time we will advance the wedge balloon that has this scoring element that is very nice because it will crack precisely the plaque. We have to do several inflations, of course, in order to prepare the plaque. You see the results here of the study that we did in Belgium. We were using the wedge and comparing this to conventional predilatation. And with the version of that semi-compliant, we were having less material use during the preparation of the lesion. One of the advantages of this scoring balloon is also not to be slippery effect inside the lesion. When we do stent boost, we can appreciate also the presence of this cutting element. And this is what I'm showing and explaining on the video, is that you will advance, retract, advance in another in order to cut in several elements. The advantage of having the wedge non-compliance is to be able to prepare much better than what we did in the Belgian study, where we had the semi-compliant version, and you will see that we will optimally prepare this lesion going to 18 atmosphere with the balloon. We are conducting that study of nano crush. This is positioning the stent right in the diagonal branch, protruding with a minimum amount and then pushing back. So we are in this OCT pullback assessing the size of the distal in order to decide of the stent. We will have here in the nano crush, we are advancing the stent, and we have the balloon in the LED just in front. And you see that what we are opening the stent, we will inflate in the LED, and that will just push interesting way to check is then to re-advance the balloon of the stent and seeing if we can re-enter. So of course we were putting a second stent in the LED, and for the POT we were using the very short shoulder of the POT. That is an advantage. You see here the preparation of this lesion, and with this, so you see nicely the structure with no crush of the stent and the use of the POT at this. So we will of course do OCT at the end in both after finishing with the kissing and repot. It's important to re-enter in the side branch by doing the POT before, and this is you see the OCT from the diagonal, the carina that is perfectly free of wires. And we have seen, you see here, the wire from the LED and proximally. And we had, thanks to the imaging, we didn't leave this lesion that looks mild, but you can see that leaving in the proximal LED a lesion that is less than 4 millimeters square, this is actually calling for problems. So you spend your time doing a CHIP procedure with imaging, you have to use all the information that is available. So we stented this proximal LED, and this is finally, if we look at the final angiogram, you see that the proximal LED as well as this bifurcation has been treated. And if we look back at all the final OCT from both branches, we have optimal stent expansion. We are ending our stent in a healthy segment, and we also address the proximal lesion. So I would say that it's very important to realize that paradigm is changing, and we will do more and more imaging to better prepare and better handle all these cheap and complex patients, thanks to imaging upfront with CT and during the procedure. It is now a class 1A recommendation to do imaging in this complex lesion. And this is really how we are going to save lives. And this is long-term data that are coming more and more from invasive imaging and non-invasive imaging. I thank you very much for your attention.
Thanks for this wonderful lecture and a wonderful, especially wonderful case example, and tell us with the help of image guided, especially for this particular case, calcified lesion and also true bifurcation lesion with a OCT guided, and we use the scoring balloon to prepare the lesion very well, and two-cent technique, POT, every step is kind of very standard. So any questions? Because of time, we can have 1 or 2 questions to discussion. Dear panels, any question?
Yes, I have a question. Can you hear me?
Yes, very well.
Thank you, Professor Carlier, for the good presentation. I have a question about POT. We know when we do bifurcation stenting, a regular balloon for proximal optimization technique or elongation stent, yes? How about in case with POT balloon? This device has this effect or not?
So it's more the overexpansion of the stent that is causing the elongation than the balloon that you are using for. The main advantage of the POT balloon is having very short shoulders and very short length. So you see, you don't have to put a long segment of stenting proximal to your diagonal branch in this case, because there was not much disease as we saw on the OCT and the angiogram. So we could do a short stenting proximally and having a balloon to do the optimization is crucial.
Okay, thank you.
Okay, thank you for the very nice case. So we will move to the next speak. So next speak. Yeah, the speaker will be Dr. Ielasi from Italy, and he's a fellow of ESC and head of the CAS lab at IRCCS Upstate Gala. I'm sorry, it's really difficult for Chinese people.
Yeah, no problem, no problem.
Yeah. So today, I think he will talk about the topic is, sorry, Is there any? Oh, it's about new tools to simplify complex PCI. Also to introduce Wedge NC and the POT balloons. Please go ahead.
So good morning, everyone. It's a great pleasure to be here and to share this presentation with you. I am Alfonso Ielasi and I'm from Milan, Italy. So in the next minutes, I will share a clinical case. So a 70-year-old female, hypertensive and dyslipidemic, she was admitted to the emergency room because of new onset atrial fibrillation with troponin increase. So it was technically an NSTEMI patient. Transthoracic echo was relatively normal, as well as electrocardiogram except the atrial fibrillation. So the patient underwent coronary angiography, and as you can see, we are facing with critical stenosis of the ostial LAD and of the ostial left circ. We have ectatic vessels with calcifications on the entire length of the lesion and of the vessel, I would say. This is the right coronary artery. Also on the right, there was some stenosis at the ostial segment because of the pressure damping, and also some plaques in the mid segments of the vessel. Based on this non-invasive functional assessment, even the right coronary artery seems to be critically stenosed. So we are facing with a patient with multivessel coronary artery disease and STEMI, normal LVEF. So the patient was scheduled for PCI, intracoronary imaging guided ostial LAD and left circ PCI, probably a two drug-eluting stent strategy at the distal left main bifurcation is needed. No mechanical circulatory support for this patient. Right radial access 7-in-6 French sheath and 7 French EBU guiding catheter. The right coronary artery was planned to be treated electively a few days after the left main treatment. So as you can see here, we have some steel frames of the IVUS run. We did on the LAD and on the left circ, so there are no doubts. It's a very critical stenosis. There is some calcium, probably more on the LAD. It's not very well visible, but we are not facing with a circumferential calcification, even if, as you can see by the monodimensional view, calcium is really diffuse. Again, this is the distal landing on the LAD, evenly calcified vessel, circumferential calcium, while on the distal L6 landing, there is less calcium. We are facing with very, very large vessels, around 4 millimeter in terms of reference. So we plan to prepare both ostial lesions using this novel non-compliant scoring balloon. I'm talking about the Wedge. It was already mentioned in the presentation before, but that was the semi-compliant version. So Wedge is composed by a streamlined nitinol 0.018 inches wire positioned into opposite direction over the balloon. The crossing profile is very low and the tip is extremely tapered. So all these features are associated with a very nice trackability of this device, and usually this is the main limitation with some other scoring or better cutting balloon. I mean the trackability related to the blades over the surface of the balloon. Wedge NC is available in several sizes from 2 to 4 mm in terms of diameter, and from 8 to 30 mm in terms of length. So a very huge huge range of sizes can be used. So these are the two dilatation we directly did with the Wedge NC 4020 on the left main to the left circ, and 4015 on the left main toward the LAD at high pressures around 18-20 atmospheres. As you can see, the balloon is very well expanded and homogeneously expanded. So this is a good sign for a nice lesion preparation. Then this is the on the left the angio after lesion preparation after Wedge NC at the ostial left circ and LAD. Then a DK crash was performed, so different steps. And finally, the double stenting procedure at the unprotected left main was optimized using a POT balloon, 4.56 mm at 18 atmospheres. So you can appreciate, as in the previous case, the feature of this device as compared to an ordinary balloon. The POT has shorter shoulder length, 0.6 mm, as compared to the 3.20 mm of a standard balloon. So this feature allows the operator to postulate really precisely at the proximal main branch of bifurcation. It's extremely useful in bifurcation treated with two stents, but even in cases of provisional stenting, and to limit the total amount of stent length in the proximal segment of the vessel. The trackability of the POT balloon is very nice, as well as the Wedge NC. This is because of the hydrophilic coating, the so-called slider, and because of the internal polymer in the structure of the balloon in contact with the wire. There are several sizes, as you can see, from 225 to 50, and in terms of length from 6 to 15. In my practice, the 6 mm balloon is the most useful to perform a very nice POT in short proximal main branches. So moving from the left main to the right coronary artery, again, as you can see, the lesions seem to be not extremely critical, but functionally they are, and there is some critical stenosis also at the ostial RCA. The vessel is diffusely diseased and calcified. So this is the baseline OCT run, confirming the critical stenosis, particularly at the mid RCA, and then some calcium on the entire length of the proximal and mid RCA. So in particular, the mid segment, as I said before, seems to be critical in terms of lumen areas. You can see on the right side of this slide, but we decided to treat the entire mid and proximal RCA segment. So because of the calcification, the relatively large diameter of the vessel, we have chosen the Wedge NC scoring a balloon to prepare the lesion, and then we left the decision open in terms of what kind of strategy, DCB only, DES only, or hybrid, to fix this relatively long lesion on the mid and proximal RCA. So even in this case, as you can see, the Wedge NC 3520 was inflated at 24 atmospheres and performed very well. Then another inflation was performed using a 4015 NC balloon at 20 atmosphere. And this is the OCT run after the Wedge inflation. As you can see and as you can appreciate, there are several cracks into the calcified lesion on the RCA. And this is a very nice and interesting finding, I would say, because usually with the scoring balloon, it is not always possible to see this kind of plaque modification after inflation. While with this NC balloon, because of the high pressure inflation, probably the nitinol wires were pushed deeply into the calcium, inducing this kind of lesions you can clearly see by OCT. So very, very nice lesion preparation. That's why we have decided to approach these long lesions using a hybrid approach. So a very long DCB was inflated in the mid and distal RCA, while a 4023 mm drug-eluting stent was implanted at the ostial and proximal RCA, then post-dilated with a 4.5 mm balloon, non-compliant balloon at 16 atmospheres. This is the final OCT run, which confirms a good stent expansion and apposition in the proximal mid RCA and a good result in the DCB target segment. You can appreciate some dissection we obviously left because of telemetry flow and no flow limitation. So this is the final angiographic result, I would say more than acceptable. And this is the final OCT at the ostial proximal RCA, confirming the nice results we have already checked before the final post-dilatation. So in conclusions, Wedge is the first non-compliant scoring balloon which may facilitate calcified lesions preparation at high pressure inflation. POT balloon is a useful tool favoring bifurcation PCI optimization. A head-to-head comparison of these devices versus actually available balloons is needed to certify their potential superiority in terms of safety and efficacy. Thank you very much for your attention.
Yeah, thank you for Dr. Ielasi bring us this very complex patients, especially I think we are impressed as a distal left main bifurcation, true bifurcation lesion and very calcified. Also, no matter from angio or from IVUS, we can see lots of calcified lesion. So any question from panel? So I do
if
have
I
a...
may.
Oh, sure, please.
So just to clarify, that's really an excellent demonstration. And what we conducted in Belgium was a study in nearly 80 patients using the semi-compliant wedge. But the case that I was showing was indeed using the new Wedge NC, which I truly believe is much better, because we also have some studies in vitro and finite element modeling showing that the amount of stress increase just at the level of this extra scoring element multiplied by 3 or 4. So, and as it was very nicely demonstrated on Alfonso's latest OCT pullback, you have really cracks that you can see on OCT just by this high pressure. I mean, you can try to do scoring at 6 atmosphere, as we have seen beautifully at 24 atmosphere. It's a bit outside of the recommended range, but it works indeed. You get a much better results.
Okay. Thank you. I actually have a question for the left main, because it's very calcified. Why you use the this scoring balloon instead of a shockwave?
Well, if you see the IVUS images, I have to say that, well, there was some calcium, but not very much concentric. And also the vessel, the reference vessel diameter was relatively large. So I felt very much comfortable to use a scoring balloon as a first option, and much more these Wedge NC, because even in case I would have chosen the intravascular lithotripsy in a different anatomical scenario, probably, I mean, in my practice, I always go with the NC balloon inflation first. So having this Wedge NC is very useful because you can first test the resistance of the lesion using an NC balloon, but you can do more because you have these nitinol wires. And in this specific case, even if I have not the IVUS images after wedge inflation, as you have appreciated by the angiographic images, the vessel was very well prepared in terms of lumen enlargement. That's why I felt much more comfortable to move forward with the case and then complete it with a double stent procedure. And even because, well, the calcification was not extremely severe at that segment. Probably on the RCA, I was much more surprised because the effect of the Wedge NC was really very impressive and really similar to that we can appreciate with IVL, even if the mechanism of action are, of course, different.
Okay, thank you. So we need to move to the next speaker. Thank you for the beautiful
Welcome.
presentation. And so our next speaker is Dr. Çakal from Turkey. He is an associate professor in Istanbul Medical University. Today, he will talk how to choose the appropriate tools for treating heavily calcified lesions. So please.
I will share my screen firstly. I want to thank you also, Borosmith, for inviting me and present. I will talk about the cracking of heavy calcification, appropriate device selection, and the role of modified balloons. Modified balloons, as you know, includes non-compliant balloons, high-pressure balloons, scoring balloons, and cutting balloons. These balloons have different features. The other option is rotational or orbital atherectomy, lithotripsy, or laser. The protruding elements of the cutting and scoring balloons create friction and reduce lesion crossability. Deliverability depends on the balloon lesion entry profile. Balloon compliance, which refers to balloon diameter expansion as a function of pressure, varies among different cutting and scoring balloons. The triangle-shaped stainless steel microblates with cutting balloons have better penetration depth compared to the nitinol or silicone wires. Besides lacking sharpness, the scoring wire of some scoring balloons are just fixed at the end of the balloon. This reduces their anchoring properties and may hamper precise focal transmission of pressure to the vessel if the wire turns round during the inflation. Normally, the profile of cutting and scoring balloons is a little bit worse than the compliant balloon, so sometimes we will need balloon predilatation. Also, adequate support and some adequate techniques will be required by the wire guide extension or anchoring technique. Normally, nominal inflation of the cutting balloon size to 1-to-1 ratio to the vessel is an option. The another option is tailoring an undersized cutting balloon with high pressure inflation may be preferred during predilatation. My suggestion is a step-by-step inflation approach comprising prolonged inflations at progressively higher atmospheres, followed by fluoroscopic imaging evaluation to check the full balloon expansion. Micro-incisions created by the cutting and scoring balloons minimize elastic recoil, thus allow more expansion of the vessel. For fibrotic and osteal lesion, using a cutting and scoring balloons may be preferable because lesions located at the ostium of the epicardial vessels have high concentration of elastic fiber and calcium, leading to elastic recoil and reduced vessel distensibility. In such situations, cutting and scoring balloon may be particularly advantageous here. micro incisions created by the cutting and scoring balloons minimize elastic recoil. For instant restenosis, using cutting and scoring balloon size to 1:1 ratio or upsize to 0.25 millimeter compared to the previously implanted stent size may be preferred. The microblades of the cutting balloon incise restorative plaques and extrude the neo-intimal hyperplasia out of the stent struts. Since the rubbery and slippery feature of the hyperplastic tissue, normally conventional balloons tend to move forward or backward during inflation, so cutting and scoring balloons may be particularly advantageous in this kind of lesions. Also, the incisions made by these cutting and scoring balloons may facilitate intravascular diffusion of the antiproliferative agents delivered by the DCBs. For concentric, focal, and superficial lesions, as well as thin calcified plaques, these kinds of plaques are more likely to respond to the cutting and scoring balloons. Also, once the arc of the calcium is more than 270 degrees, the benefit of the cutting balloon is more evident. The crossability and trackability of the scoring balloons are better than the cutting balloons, but we have new generation cutting balloons and scoring balloons who have an improved profile. Also, the penetration depth of the cutting balloon by microblades is better than scoring balloons. Once we compare the atherectomy to the IVL, IVL is a more new generation technique and more user-friendly, less technically demanding needs we have. The learning profile curve is relatively low. Profile is better than the atherectomy, and we don't need dedicated wires. Also, you can able to protect the side branch by IVL. No wire bias effect is observed with IVL. Atherectomy has some problems like potential device entrapment, slow flow, no reflow, and perforation risk. Here is an example of off-label use of rotablation technique, severe bifurcation calcified lesion. Leaving a wire in a microcatheter would prevent the damage of the rotablated device to the side branch wire. As I mentioned, the risk of IVL, the potential risk is relatively low. In this real-world data, you see that the perforation risk is less than 1%, but not zero, which means that even IVL not very safe. The ECLIPSE trial presented in last TCT comparing orbital atherectomy versus conventional balloon angioplasty in calcified lesions. 2,000 patients were randomized to orbital atherectomy versus conventional angioplasty. The first primary endpoints included in-stent minimum stent area by OCT. The second primary endpoint was 1-year target vessel failure rates. The secondary endpoints included procedural and strategy success. Most of us would assume that there will be crossover from balloon angioplasty to the orbital atherectomy arm, but you see that the crossover rates were so low in this study. In the OCT group, minimum stent area did not differ between orbital atherectomy versus balloon angioplasty arm. Also, target vessel failure rates about 10% and were similar between orbital atherectomy versus balloon angioplasty. This figure shows us the importance of imaging. Once taken into consideration imaging, if you did the case with OCT, you will better have lower target vessel failure rates. The conclusion of this study was the orbital atherectomy did not improve minimum stent area or reduce target vessel failure compared to the conventional balloon angioplasty. Extremely calcified lesions that the operator believed uncrossable or undilatable were excluded from this study. Most of the lesions were qualified based upon angiogram, but with the help of intravascular imaging, the target vessel rates declined significantly. Atherectomy shouldn't be used systematically for whole calcified lesions, but in case of balloon failure or uncrossable lesion or lesions that high severe calcified that the operator deemed undilatable, yes, you can use the atherectomy technique. This is another trial which was published in Yurii Intervention, prepare calcified lesion, which compared rotational atherectomy versus modified balloons. Here you see that the 3 years target vessel failure, MACE rate, or TLR rates did not differ between both arms, but especially ostial lesions and longer lesions with more than 27 millimeter were independently associated with the occurrence of target lesion revascularization. This is another trial, the first prospective randomized trial comparing the safety and efficacy of 3 techniques, which was published JACC in last week: rotational atherectomy versus lithotripsy and laser for calcified lesions. 171 patients were randomized to these 3 groups. When we evaluated the outcomes, IVL was non-inferior to the rotational atherectomy in terms of stent expansion measured by OCT. Laser didn't reach the non-inferiority margin compared to the rotational atherectomy. Also, when we compared the differences, the 3 groups were similar in terms of minimum stent area, procedural success, and rate of complications, with IVL had a numerically lower complication rates in this study. Approximately 10% of the patients required another plaque modification technique in this study. Angiogram is not a good technique to evaluate the features of calcium. Here on this table you can see there are several aspects of calcium: eccentricity, depth of the calcium, thickness of the calcium, and length of the calcium. These different features can be seen here, from eccentric to concentric, from thin to thick, from superficial to deep, or calcified nodules. Here you see the calcium modification algorithm. Uncrossable lesions usually require atherectomy or laser. For crossable lesions with eccentric calcification without high-risk features for stent under expansion can be treated with either non-compliant cutting or scoring balloons. Concentric calcification or calcium with high-risk feature for stent under expansion can be treated with atherectomy or IVL. Nodular calcium also can be modified by using atherectomy techniques, with emerging evidence that IVL may be also effective here. These are the calcification assessments by the IVUS. Here on the left side, this is an example of concentric calcification. Posterior shadowing and lack of reverberation suggests that this calcium is so thick. Another example of concentric calcification with an arc of 360 degrees. The third picture shows us an eccentric calcification, and the last picture you see that a calcified nodule protruding to the lumen. We have calcium score, IVUS. We can calculate the calcium score by IVUS and OCT. If this score is more than 2, which means that the risk of stent under expansion is so high, in this case of situations, we will need plaque modification techniques with special devices. Here you see that the footprints of calcium incisions and fractures after cutting balloon. Also, this side shows us calcium fractures following IVL by IVUS. Professor Carlier also mentioned about this slide, so I will switch this slide. And this is another calcium management algorithm which was published in European Heart Journal. This is the calcium modification algorithm based upon angiogram or CT scan. First of all, we will avoid direct stenting. If the lesion is not uncrossable, which means that you will need rotowire or laser. Once to cross the lesion, just use a small balloon and predilate and evaluate the lesion. If you have an suboptimal result, which means that you will need plaque modification techniques like NC, cutting, scoring balloon, lithotripsy, rotational or orbital atherectomy. After modification, evaluate the vessel, evaluate the NC balloons, stent NC balloons expansion. If you have an optimal result, go with stenting. If you don't have an optimal result, you will need another modification technique. This algorithm is based upon the assessment of intravascular imaging. If you see a severe moderate calcification on angio, just imaging, do the imaging. And If you cannot cross the lesion, use a small balloon. If you are not able to cross the lesion, you will use an rotawire or laser. After the imaging, you will evaluate the calcium score by either OCT or IVUS. According to this score, if the risk of stent under expansion is so high, you will go with the stent plant modification techniques. Or this score is low, which means that you can use cutting scoring balloon, NC balloon, or high pressure balloons. After cracking the calcium, evaluate the lesion with either OCT or IVUS. If you have an optimal result, go with stenting. But if you don't have an optimal result, you will switch to another plaque modification technique with either lithotripsy, high pressure balloons, or a larger burr with repeat rotational atherectomy. This is the summary for uncrossable lesions atherectomy. If we have a deep calcium, IVL is better for us for the cracking the calcium. For crossable long lesion, evaluate the lesion with NC balloon. If you don't have an optimal balloon expansion, go with atherectomy. If you have a deep calcium, also IVL will work better here. For crossable focal lesion, NC cutting scoring balloons may be effective. For IVL, calcified nodules, CTO with a wire intraplaque, if you have a calcium behind the stent with an instant restenosis, aorto-osteal lesion, or if you have a severe bifurcation lesion and you want to protect the side branch, IVL would be more appropriate for plaque modification. Here I have two cases. This is the 54 years old male, recurrent instant restenosis history. He came presented with exercise effort angina symptoms. Again, instant restenosis we have here. We tried to predilate with 3.54 20 millimeter wedge NC balloons. You see that the opening of the balloon, even if not adequate, appropriate after scoring balloon. We tried to predilate it again. You see our attempts, but unfortunately, we didn't have a good expansion of the vessel. So we go with the 12 millimeter IVL. Here you see our attempts to open the vessel. But even with IVL, we couldn't able to get a good result. We used a cutting balloon then for 10 millimeter Wolverine cutting balloon. We tried to predilate it again. After that, we use DCBs. Even if we don't have a perfect result, we obtained optimal result. The second case, an 68-year-old male with hypertension diabetes. Also, he had another recurrent repeat revascularization for instant restenosis, and he presented with typical angina symptoms. 3 months ago, he had a balloon angioplasty again. You see that there are two stents, but one of the stents opening is not good. But unfortunately, the operator implanted the stent there. First of all, we want to predilate it again with the high pressure balloons. 26 atmospheres. But unfortunately, we couldn't able to open the vessel again. So we go with this shock wave. We use the shock wave. Even with shock wave, you see that there is not a good opening of the vessel. This is the image after shock wave. Not a good expansion of the previous stent, even with shock wave. 3 days later, we wanted to do stent ablation with rota. We had 2 millimeter rota. Here you see our attempts. Finally, rota device crossed the lesion. Then we use cutting balloon. with high atmospheres. And finally, we did a DCB to the lesion. Even with several attempts, there is we didn't have a very good expansion of the vessel. Thank you for your listening.
Thank you for Dr. Çakal gave us a very excellent talk about actually it's a toolbox about almost all the devices to treat a very calcified lesion and give us a very clearly flowchart and experience about how to treat very calcified lesion. I'm sorry because the delay, so we need to move to the next speaker. Okay, thank you again. Next speaker is Dr. Rola from Poland. So he's an associate professor in Wrocław, Poland. So today he will talk about the CHIP PCI toolbox. Please go ahead.
Good morning to everybody in Europe and good evening to our Asia friends. Today I am pleased to present you two complex cases in which the Alveo balloon catheter allowed me to avoid big problems. Due to the time limit, I think that we need to be in a rush and start the presentation directly. So the first case regards 75-year-old man, active heavy cigarette smoker, which was admitted with classical risk factors, cardiovascular risk factor, which was admitted to our hospital due to a non-ST elevated MI. In laboratory assay, we could appreciate a slightly elevated troponin level. Echocardiography revealed significant impaired LV function with ejection fraction reaching 25–30%. And in ACG, we could not observe any ST elevation. And this is the initial angio. We can appreciate diffuse disease, eccentric calcified lesion in the left main, a long lesion in proximal LAD, chronic total occlusion of circumflex along with intermedius ramus, and some retrofillings to the right coronary system. Here are some more views on a calcified lesion in the LAD and retrofilling of a right coronary artery, diffuse disease left main, and some shots on the right coronary syndrome, diffusely diseased, ostial critical lesion, and then in mid part, a chronic total occlusion of the right coronary artery. A patient was initially qualified for the local heart team assessment. The syntax score was relatively high, reaching over 50 points. And after the heart team discussion, due to the advanced pulmonary disease, the patient was disqualified from the surgical approach, and therefore we decided to perform the high-risk PCI with a Impella CP support. And the PCI was performed by the right radial access 7 French, and Impella was inserted by the right femoral standard access. The procedure, we decided to start the procedure with the intermedius ramus. In my evaluations, it was relatively simple CTO, which reached out only 1 point, and with antegrade wire escalation technique, I was able to cross the lesion. Unfortunately, microcatheter gets stuck in the body of the CTO, mainly due to the calcifications. And this was the turning point for Alveo. I exchanged the microcatheter on this balloon catheter, and I was able to cross the lesion with 0.75 balloon and perform a high-pressure inflation, several high-pressure inflation. In the next step of the procedure, I was able to advanced bigger size of Alveo balloon catheter and also expanded fully with 2.0 on 20 atmosphere. Unfortunately, with the higher size of the balloon, I mean 275, we could observe a dog bone effect despite use high pressure inflation. And at this point of the procedure, I decided to perform the IVUS to recognize what is the problem. And in the middle of the screen, you can appreciate the problem. It was a 360-degree calcium ring inside the vessel. After evaluation of this fact, I decided to use a shockwave intravascular lithotripsy 3.0 12 balloon catheter. The second generation, after 90 pulses, I could observe a full expansion of the stent. The lesion was re-evaluated in IVUS, and we could appreciate cracks inside the calcium ring. And it was followed with the long drug-eluting stent implantation, 2.75 on 30 millimeters, with additional post-dilatation with 3.0 at the high pressure. And here you can appreciate a good angiographic result which was confirmed, of course, in the IVUS with a really good stent expansion and apposition, reaching MSA reaching 5.2 millimeters. And in the next part of the procedure, we decided to perform the PCI of left main along with the LID. After the advancing workhorse wire, we exchanged it on a wiper wire and performed the orbital atherectomy due to the long calcified lesion in LID along with the left main. And after several runs, 12 low-speed runs supported with 6 high-speed runs, here you can see the angio after the runs. I decided to perform the high pressure inflation balloon, and we can appreciate a good stent balloon expansion. And it was followed with the implantation of two long drug-eluting stent, 3.5 and 4.0. And it was optimized with the non-compliant balloon and POT in the left main 5.012 at the high pressure. And here you can appreciate some final shots of from the LID and left main, and good stent expansion was of course confirmed with the IVUS. And in summary, we can say that we used almost 200 milliliters of contrast. The vascular access point for Impella was closed with the Manta ProGlide, one Manta and one ProGlide. The patient at the discharge have a significant improvement in the LV function, and it reached over 40%. And we planned patient for the shuttle evaluation in terms of the chronic total PCI of the chronic total occlusion and potential ICD implantation. And the second case in which Alveo allowed me to solve my problem was a case of 65-year-old female with hypertension and hyperlipidemia, which was also admitted to our hospital due to NSTEMI. In echo, we could appreciate preserved LV function, no significant changes in SV in ACG. And initial angio, we can appreciate a multivessel disease, a long lesion in the mid part of the RCA, a chronic total occlusion of LAD in the mid part just after the development of the big diagonal branch, and chronic total occlusion of a single flex. The patient was also referred to the local heart team. Unfortunately, due to lack of the willing of patient to, the lady didn't want to perform the CABG, we decided to perform the PCI. And the PCI started from the right coronary system. We performed the aggressive predilatation with 3.5 balloon, followed with the long drug-eluting stent implantation. This was optimized with the another non-compliant balloon with the higher diameter. And here you can appreciate the angio. We could notice a significant dissection in the distal part of the vessel. Therefore, I decided to cover it with additional overlapping drug-eluting stent, and here is the final view of the RCA. In the next step, I performed the CTO of LAD. It was relatively simple to wire the LAD. The lesion was predilated with the 2.0 balloon, because I supported the diagonal branch with additional wire, and it was followed with the 2.75 millimeter long drug-eluting stent, and it was optimized with the non-compliant balloon. And here you can appreciate the final angio. There you can see a significant dissection in the distal part of the LAD, which was also diffused. And at that point of the procedure, I decided to cover it with the additional drug-eluting stent. Unfortunately, there were some difficulties in delivery of the stent to the distal part of the vessel. Therefore, I decided to use a body wire technique, which allowed me to deliver the drug-eluting stent balloon and predilate it and deploy it successfully in the distal part of the LAD. And this is the final result. Probably probably some of you can ask the question, where is the turning point in this procedure? And you need to wait few minutes, because I need to be honest with you, I forgot to take off the body wire before the distal stent implantation. And after removing a body wire which was trapped by the stent, you can appreciate that something had changed with the stent structure, a distal stent structure. The stent was deformated. You can see it on the angio. And there were huge problems with reaching the distal part of the vessel. I was unable to cross it with even small profile SC balloons. Therefore, I decided to use a guide extension. It didn't help. I still had some struggling with reaching the distal part of the vessel. And at that point, the Alveo showed up in the procedure. I use Alveo with additional guide extension and some crawling techniques, which allowed me to deploy the Alveo at the distal part of the vessel, and in the next step, with some crawling technique and guide extension, put there another higher size Alveo and predilated this lesion. And here you can appreciate the view after the non-compliant 2.5 balloon inflation. Due to the significant stent deformation in LAD, I decided to use another drug-eluting stent to cover it and to fully expand the struts which were inside the vessel. And here you can see the stent deployment and additional post-dilatation with the high-pressure balloon size a little bit higher than the previous stent implanted with, and there was 22 atmospheres. And this is the final view. The good angiographic appearance was confirmed in the OCT. However, due to some technical issues, I cannot provide you an OCT image in this presentation, but I guarantee you that the stent was fully expanded. And in summary, I can say that Alveo balloon have many benefits, especially which in my practice reflects. It's a low crossing profile. It's easy to advance even in difficult calcified lesion. We've got wide range of catheter size, especially the small size catheter are really useful. and it's really easy to deliver even after the previous predilatation. And I, in my clinical practice, use an Alveo HP in several situations. It's like a special task technology. I like to use it in CTO lesions, in preparation of so-called uncrossable lesions. It is really useful in two-stent techniques, especially those where you need to cross the double stent layer, like DK culotte, DK crush, and it's, in my opinion, it's perfect for the so-called crawling technique in PCI. And that's all for today. Thank you for your attention.
Thank you for Dr. Rola. I'm very impressive about the cases you did, especially the first case, very complex patient, poor left function with support of impella, and you did excellent job. So any question from the panel? We can ask the one question. I have a question for Dr. Rola. So in what kind of scenario you use this device? I mean, Alveo HP. You always use a small balloon as a preparation of the lesion, or you use it as a post-dilatation balloon?
I prefer to use it for the lesion preparation, and I prefer it for so-called hard lesion preparation, where I assume that I will gonna have a problem with advancing the balloon. That so in the tight calcified lesion, for example, for the opening the struts of the double layer stent, it is a really good balloon for such a special task. And I really like to use the small size balloon, 0.75 or 1.0. It's like a special task balloon at my toolbox.
Okay. Thank you for your experience share to every one of us. Thank you again.
Thank you.
So let's move to the next speaker. So next speaker is Dr. Melen from Ukraine, and he's interventional cardiologist in First Medical Association of Lviv. So today he will, interesting topic. He will give us a talk about the wedge balloon is a necessary device in strategy PCI with drug coating balloon. Please.
Hello, thank you for introduction. Can you see my slide?
Sure.
Yes, it's okay. Thank you for the opportunity to speak at this webinar and share of my experience with using wedge balloon in strategy with DCB. As we know, event related to implant stent never and harmed the patient throughout to implant his life, and which is 3% in the year. And we know about negative effect of the implanted stent, about lack of pulses coronary artery, and this component of stent could provocate restenosis. We know that in our daily practice, the number of patients with complex PCI is increased, and which is 30% from the total amount of PCI. We know about Ultimaster registry data that the prognosis in patients with complex coronary lesion is much worse. That's why we everyday practice try to do a hybrid approach or approach with DCB. We know about main aim is optimal lesion preparation, and we using different type of balloon. But we know in the Chinese colleagues data about scoring balloon that this balloon has better angiography result after predilatation. And I want to present two cases. First case is a female, 65 years old. She is admitted in our hospital in inferior STEMI, chest pain during 1 hour, and we see on ECG ST elevation, 3 and inferior leads. Troponin level is increased, and we immediately did a coronary angiography, and on coronary angiography we see culprit lesion on CX branch, and we see long diffuse disease on LAD in different view. And we see right coronary artery stenosis distal part and the proximal and ostial part disease. And after that, because patients has chest pain and it was STEMI, we decide to do primary PCI. We did provisional destenting CX with kissing and POT for in this bifurcation, and we see good angio. Is this after implant stenting? We see side branch close. We reopen this branch and see good angiographic result. And after that, we have hard team discussion about revascularization strategy, because patient residual syntax score was more than 28, and we recommended cabbage, but the patients refused from cabbage, and we decide to do PCI with IVUS, and we start in the right coronary artery and insert IVUS eagle eye and see we see significant disease PDA and distal right coronary artery and fibrocalcific lesion in the ostial RCA. And after that, we decide to do more aggressive predilatation, particularly in ostial right coronary artery, and we use it Wedge semi-compliance ballon 3 by 50 and inflate 80 atmosphere and several times. And after that, we implant 2 stents. One stent we implant in distal right coronary artery, and proximally we implant DS Resolute 3 by 28 and to do post dilatation proximal stent, and we have this result on right coronary, good result in right coronary artery, and recheck IVUS this result. We see good MSA distal stent and good and oval shape stent in ostial RCA with good MSA more than 8 millimeters square. After that, we will do PCI on LAD, and we check LAD with IVUS, and we see fibrocalcific lesion in different part of this LAD segment, yes, and we see fibrocalcific lesion in proximal part of LAD. Because after that we predilatation using scoring balloon, predilatation with scoring balloon Wedge 2.75, and after that NC balloon 2.75 and 3.25 inflated by 12 to 20 atmospheres, and check result into orthogonal view, and we see residual lumen on mid segment, and we check IVUS, and IVUS show us residual lumen and proximal LED more than 5 millimeters square, and dissection less than 90 degree. And after that, we decide to stand mid LED, provisional standing mid LED, and after that, more aggressive predilatation proximal part of LED, because we want to avoid full metal jacket for LED, and we don't want standing LED left main. And after that, we take more bigger wedge balloon, 3.25 by 15, and inflate several times from 10 to 18 atmosphere, and recheck IVUS. And IVUS, we see good MSA on the implanted stent in the mid LED, and on proximal lesion we see good MLA, more than 6 millimeters square, and medial dissection less 90 degree involved to media. And after that, we decide to inflate restore DCB balloon in proximal LED 3 by 25, and recheck angio, and we see dissection type BC and TIMI flow 3 after DCB, and patients discharged from our hospital on second day and prescribed to aggressive DAPT, and we recommended control angio after 6 months. And patients come back in our hospital after 6 months. Patients feel good without angina symptoms and without ECG ischemic change, echocardiography without regional wall abnormality, and good injection fraction. And on angio, we see good result on right coronary artery, stent without restenosis, and another view, and LED, and previous segment where we implant DCB, it's a good result. We see healing dissection, and the good stent without restenosis. And patients now feels good, and maybe after 6 months we try, we recommended coronary angiography. And second case, young gentleman with non-STEMI, 47 years old, symptoms chest pain during 3 hours, and admitted in our hospital with non-STEMI. ACG, we have negative T wave in anterior leads, wellness syndrome. We had increased level troponin, and on echo hypokinesia anterior wall, and we immediately do angiography, and on coronary
Recording in progress.
To avoid stent implantation, and we try to do immediately lesion preparation using scoring balloon, wedge balloon 3.5 by 15 and inflate 40 and 20 atmospheres. Recheck angio into view looks good, but it's some residual. We see residual lumen less than 20%, and we want to do better angio result and decide more aggressive predilatation using another scoring balloon, bigger scoring balloon, Wedge 3 point.
Recording in progress.
Flow without flow limiting dissection, and we decide to cover this lesion DCB ballon, restore ballon 4 by 15, and final angio we see good result, TIMI3 flow, and good side branch, TIMI3 flow 2, and patients discharged from our hospital on second day on dual antiplatelet therapy, follow-up 3 months after PCI. Patient feels good without angina symptoms and without ACG ischemic change. Because I have conclusions, scoring wedge balloon is good device for optimal lesion preparation and controlled dissection. Wedge balloon has good deliverability and profile for advanced in difficult coronary artery anatomy and helps implement a strategy leave nothing behind or reduce the amount of metal in the complex coronary lesion where we want to use DCB. Thank you for your attention.
Okay. Thank you for Dr. Melen. I like the strategy, both of the three vessel disease LAD lesion, and also as I remember, Dr. Ielasa also present a very similar RCA diffuse lesion, and we don't want to treat the whole vessel as metal jacket, so we call it a hybrid strategy. Some part covered with stent and the other part covered with drug coating balloon, and the patient avoid long DES and avoid ISR in the future. So very good, very nice presentation. And any question from panel?
I don't know. Do you have any data showing that after scoring, it would be better to use rather paclitaxel or one of these newer balloon with solution, for example? Do we have anything out there so far?
No, I don't know data about this, but I think we know data about the paclitaxel balloon when we must to do a dissection and then we to do less lost lumen, yes, and if wedge scoring balloon did dissection, I think it could be maybe in future better.
Okay. Okay, thank you. Now let me introduce the last speaker of tonight, my colleague, Chinese colleague, Dr. Cui from Anzhen Hospital. So he will present a pre-treatment strategies for high resistance lesions. Dr. Cui, please.
Okay. Professor Guo, dear professors, thank you for your invitation. So I will share my cases. So this is more simple cases. Compared to the previous professors. So I'm the doctor tackling with primary PCI. So when the resistant coronary intrastent restenosis meets the primary PCI, what strategy will we choose? So let me introduce this case. This is a 65 years old female, and she presented persistent chest pain and related to the jaw. Her ECG shows from other hospitals showed transient anterior wall ST elevation, and this relieved in 3 hours after dosing nitroglycerin and referred to our hospital. She has a previous history of PCI, and she has a previous left anterior descending artery stent 10 years ago. She has a history of dyslipidemia on statins and ezetimibe. She is no smoker. So the physical examination generally is normal. Also, we found some fine rheos in bilateral pulmonary fields, but the rest examination was unremarkable. So we also find the troponin I was elevated and the BNP was elevated. However, the LDL-C level generally is good. So the echocardiogram showed a reduced left ventricular function and a hypokinetic anterior wall motion. So this is the EKG of the patient. We can also find the elevated ST segment was recovered in the anterior wall segment. Because we know this might be the culprit lesion in the LAD, so we do the angiography first in the right coronary artery. The right coronary artery showed generally is normal, some plaques, but no severe stenosis. But also in this angiogram, we find that there was severe calcification and a long stent in the LAD stent, and there is some collateral branches from the right coronary to the LAD. We directly put the EBU 3.5 to the ostium of the left coronary artery, and we do the left coronary artery angiogram, and we showed that there is generally normal circumflex, and we found that there was a very severe stenosis intra the stent of LAD, and the blood flow is STEMI2, and we find there was also severe stenosis in the ostium of the diagonal branches. We decide to tackle this. Decide to tackle this lesion. So we first use 1.5 ballon, pre-dilation ballon, to dilate the lesion into the stent, and also dilate the ostium of the diagonal. And after that, we made angiogram, and we showed that there is still severe stenosis intrastent and in the bifurcation of the diagonal. We go on pre-dilate the diagonal with the 1.5 ballon to recover the blood flow of the diagonal, And after that, we found the blood flow of the diagonal was recovered, and we found that there is a very heavy calcification, and also this is a bifurcation lesion, and this is an interesting restenosis. Thus, we decide to use the wedge scoring balloon 2.5. So we pre-dilated the lesion at 12 atmosphere. So we can see there is generally the balloon was inflated good, but after we use the OCT, we showed that there is a very severe stenosis in this area, in the distal stent area. And after predilation, so we can find some the stenosis was generally relieved. So the minimum area in the distal stent area was 2.39, and after predilation of the bifurcation, so the area can achieved at 4.67. Thus, we decide to use the wedge scoring balloon to predilation the distal stenosis intra the stent, and at 60 atmosphere, and also we predilated the bifurcation, use the same balloon at 20 atmosphere. So after that, so we find the stenosis was obviously relieved. Thus, we use a drug coating balloon 3.0 plus 35 millimeters, and we deployed the DCB at 8 atmosphere. So we can see the DCB was inflated quite good. So after that, we use OCT to check the result. Also, we can find that the bifurcation blood flow is generally okay. Although the bifurcation has some residual stenosis. The stenosis is less than 30%, and this we can find it by OCT that the minimum area of the bifurcation is 5.76 millimeters squares. So this is a case of primary PCI. So when we tackling the STEMI or non-STEMI as the former professor showed, so we often meet some high resistance lesions. So how do we tackle with this kind of with lesions? Also, this case we can use some laser or some other cutting balloons, but we use wedge non-compliant scoring balloons. So these balloons have controlled intima scoring and reduce elastic recoil, avoid severe dissection. So after that, we also use OCT to check the result and to guide the PCI procedures. So in the 2025 American guidelines for managing ACS, so the intralumen examination was the 1A recommendation. So this is the case I provide. So thank you for your attention.
Thank you for Dr. this beautiful case, especially according to current guidelines, stent failure should be guided by imaging. So beautiful OCT guided drug coating balloon to treat ISR. So because of the time, finally, I would like to invite Dr. Caliber gave us a summary and closing of tonight's session. Dr. Stephanie?
I'm there.
Yeah, please give us a closing of the session.
I think that we had beautiful examples on the use of imaging in order to proceed to CHIP procedures. And these procedures are only safe if you know exactly what you are doing. And there is no guesswork on the size of the vessel, taking a too large balloon. It's better like precisely addressing the lesion that needs to be cut, that needs to be scored, that needs to be perhaps not stented, but well prepared after scoring. You can have a drug-eluting balloon. It's beautiful example why it finally became a class 1A indication to do imaging as well in Europe as in the US guidelines. Thank you to all the speakers. This is PCI as it should be done in 2025.
Thank you. Thank you. Also, I think I would like to thank you all the speakers and thank for the company gave us so many products, good products, and especially a lot of innovation to help the doctors who can did very complex PCI and get very good result. So thank you and have a good day. I think it's time to say bye.
Thank you very much.
Bye, everybody.
Bye-bye.